So, and I'm going to be talking about the importance of a multidisciplinary team, as well as putting together, having a net expert team on your back. So, if I was giving a medical talk, I'll tell you about financial support, small, that I have received to give my opinion about drugs. These are my disclosures. I think it's as fair that you know about them. I am still allowed to open clinical trials because they're small, but they're there. So I'm talking about multidisciplinary teams, right? So it's encouraged by both the European and the North American Endocrinology Tumor Society. And why? So that's where I can stop and go home. Evidence that is better survival in patients that are managed in centers that have multidisciplinary teams compared to standard practices. And this is known for multiple different cancers, and that's why you should have a team working with your local team, if that's the case. So you probably already saw that, but when you go and see a neuroendocrine expert or a neuroendocrine team, you're going to learn that the incidence of neuroendocrine tumors is increasing, and this is a slide that we like to show. Also, you're going to learn that it's very prevalent. If you take about all the cancers, especially within GI, is actually the second most seen GI cancer, if you put all the neuroendocrine tumors together in the GI clinic. So you're going to learn that you are not alone, that there are approximately 170,000 patients living with neuroendocrine tumors or neuroendocrine neoplasms in the United States. So the second thing that you're going to learn is that you are not alone in the sense that it might have taken you a lot of time to figure out what was wrong and what were your symptoms. And we know that it can take a lot of time to finally get diagnosis, because initially you can start with some vague abdominal pain, and that can go for years before you eventually develop metastasis, or meaning spread to the liver, that can lead you to have more symptoms such as the flushing and the carcinoid. So many times you might have thought, maybe I'm crazy, maybe this is all in my head, maybe I have IBS. That's not true. It just, that's how the disease presents, and you are going to learn that, and you're going to be reassured by your multidisciplinary team about that. You're going to also, when you see a multidisciplinary team with expertise, you're going to feel reassured to know that when you mention all the symptoms, it things that the team is very familiar with and might be able to help. So the diarrhea, the abdominal pain, the anxiety, all these things that you have as a symptoms are going to be something that your team is going to take very seriously, because they know that's part of the disease. So third thing that you're going to learn, Dr. Anthony already mentioned, the treatment is complicated. And how to treat, how to diagnose. First, you're going to learn and sit with your team of experts and say, this is a well-differentiated or this is a poorly differentiated tumor. How do the cells look under the microscope? Do they look fairly similar to normal cells, or they look very nasty and aggressive, which is more the poorly differentiated tumors? And that's important because the treatments for a well-differentiated versus a poorly differentiated tumor are completely different. So Dr. Anthony already talked about the grade, so we don't have to talk much about that. But you know, do you have a grade 1, a grade 2, or a grade 3 tumor? And if you have a grade 3 tumor, is that a neoplasm? Is that a well-differentiated tumor, or is that a poorly differentiated high-grade neuroendocrine carcinoma? And again, that's important for your treatment decisions. You're going to be informed about your Ki-67 and how that can impact your treatment decisions. You're also going to learn where your disease is and how that can impact the treatment. For example, for pancreas tumors, we use the capecitabine and temozolomide that Dr. Anthony mentioned in one of his slides that was initially published by Dr. Strasberg. It works extremely well for pancreatic cancer. It doesn't work that well for small bowel cancers. So small bowel neuroendocrine tumors, we would much less. So it's probably not, even though it can be a first option, for tumors, if they start in the pancreas, it's probably not going to be the first option when you need to change strategies from a somatostatin analog for a small bowel neuroendocrine tumor. So the site matters. You're also going to learn, I was explained before, about is this a functional versus a non-functional tumor, and discuss with your team which biomarkers or tumor markers should be followed, if any. Sometimes if your tumor is not functional, you don't need to necessarily follow many tumor markers. So you're going to also have, when you go to visit a multidisciplinary team or a center of excellence, typically review of the pathology, right? So you had the initial biopsy perhaps in a place A, and then you go to the center of excellence, and then that's going to be revised by the pathologist team there that is very much educated about neuroendocrine tumors. It is interesting, this abstract that was presented in the European meeting showed that once the pathology gets revised, about 50% of the time there is a change in the final pathology. And that's important because in this study it led to a clinical impact of 30% in making treatment decisions for the patients. And that's for things like that you should have a multidisciplinary team and a center of excellence on your back. I think it's just me because yesterday I was giving a talk and then I just hit something and dropped my thing and I couldn't find it in the middle of the talk. It was fun. So things happen to me. All right, so this is another study that was actually presented was published looking at one center of excellence in Italy, and they look at the chart of patients from 2014 to 2018, and they included 195 patients. And when they were discussed in these multidisciplinary team meetings, so 83% of the patients actually had to have more imaging done. 43% had to have more histology obtained, meaning potentially more biopsies. And in 30% was a combination of the two things. The staging of these patients was changed in 30% of the cases, the diagnosis or the grading in 17% of the cases, and there was a clinical management change proposed to these patients in 50% of the cases. So that's big. So this is another study following different centers of excellence in Europe, and here the change was almost 60% that you can see. So, and then, okay, so and Dr. Anthony alluded to that. So why do we need a multidisciplinary team? If you open the guidelines, and this is for last year, but, and you look and try to follow the algorithm, after you have your diagnosis, you have to decide, do I start on any treatment, if any? Can I go for surgery? Is that indicated for me? And if you progress after your initial treatment, let's say with lanreotide or octreotide, then you have all these options here. And your physician or your team in the community might not be familiar with all these options and which option fits you. So that's when it's good to have this discussion with a multidisciplinary team and a center of excellence for NATs. And here's another way to see and to try to decide, and that's when the multidisciplinary discussion helps, right? You have the disease burden, you have the aggression of the tumors, and then you take in consideration all these options to try to figure out what's the best option for you. So here this patient has initial diagnosis with, and presented, had a biopsy, and we see that the patient has a mesenteric mass, so a tumor in the belly, and then also multiple liver mets here, right? You can see here, here. And so what you do with this patient? You know, should this patient have surgery and try to resect it all? Probably not, because the mesenteric mass is very deep, attached to the vessel, so it's hard to dissect. Should this patient resect the liver mets anyway? Or should they just start with some systemic treatments such as a somatostatin analog? Or should we do nothing? All these options, just for the same patient that can run to someone's mind. So again, what we consider resection, if we do a resection, if it's not for a curative intent, would they help with avoiding future problems with obstructions? would improve the abdominal pain. Other considerations when you make this decision, is that close to any vital organs, or are we going to take too much? If it's possible to resect, is the resection going to be so big that the complications or the recovery from the resection are not worth it? Is the patient going to have diarrhea because a long piece of the small bowel is resected and you have absorption problems? All this should be discussed in a multidisciplinary team, with a multidisciplinary team, and I'm sure Dr. Ganji is going to talk more about that. So for systemic treatments, is that time to start somatostatin analogs? And then when, at the time of progression, which options should be used? So this is a survey that was done with patients in 8 countries, I believe, through NCAN. And this is what they mentioned in terms of what was discussed and what can be discussed when you see a neuroendocrine tumor expert team. So in green is when you visit a center of excellence. And in red, or yeah, I'll call it red, is when you don't. And then you can see that results or tests were discussed more frequently. There was a change in symptoms because probably you were heard. You feel well. There was also discussions of new treatment options for you, discussion of research in the field. I spent a lot of time sharing some excitements that we have in the field. Many of those excitements are related to trials from Dr. Chalman. We discussed your emotional well-being. We discussed the opportunity for patient advocacy groups and so forth. So here is also in terms of patient satisfaction when you visit a center of excellence and when you don't. I have a very close relationship with my net medical care. That's higher when you visit a center of excellence. I have full confidence on my net medical team. It's higher. My net care providers provide emotional support, and I feel that I left with a lot of questions after meeting. And this is interesting. It's less with the Center of Excellence. And I think it's because we talk so much and we give so much options that it sometimes can be a lot to digest at once. But one thing that I think we have a lot of room for improvement, and this was eye-opening in terms of the surveys, 40% of the patients that visit the net specialty centers do not feel that we coordinate well with internally to make sure that is a good experience for the patients, and also in terms of coordinating with your local docs. So we can do better in terms of communication, and I think all of us try really hard to improve on that. So, so a net expert on a net things is important because deciding if surgery as an option and what type of surgery is the best for you, deciding the best starting to start the systemic treatment on your case, deciding the time to change a systemic treatment. Are the tumors really growing in a clinically significant manner? Because if the tumors just grew 2 millimeters, 3 millimeters in a year, that's not time to change things. Why are you going to change things? And the scans can say that, but then when your expert team opens the scans and show it to you, you understand that, okay, the report is more scary than actually scans. So that's why it's important to review with them. Deciding the best imaging modality that's good for you and the frequency of the scans. Some patients might need to get scans every 4 months, some patients 6 months, some patients within every year, sometimes even every 2 years if the disease is really slow growing. So this is all has to be discussed with your team of expertise. Suggested on strategies to deal with your symptoms, coordinating your care with your local doctor, and identify clinical trials that are good for you. So clinicaltrials.gov is a search tool that we can use to look at clinical trials. It can be very overwhelming. When I type this research, we got all these trials, and then your net expert physician can help you digest all this information and figure out which trials are applicable to you, if any, in what location, and contact you with the, help to contact the teams that have the trials if you don't have the trials on your city. So all of this is important when you're taking care of patients. Also helps to eliminate confusion when you see neuroendocrine team of experts. There's a lot of confusion in the diagnosis, and actually there's a paper they argue and suggest is how to deliver the news about the diagnosis. So if you go to a NET Center of Excellence, that will be very easy to understand, digest, and you should expect that from the team. Also can help with trust issues. We know that because of the delay in diagnosis and from the sometimes misunderstanding your symptoms, you lose trust in your medical team. And having a team that understands you might help to rebuild the trust. And the trust is important because we know that if patients don't trust their physicians or their teams, they might not follow the recommendations, and that can affect actually the outcomes and their survival. So, few things about thinking about going to search a NET expert or a NET Center of Excellence for neuroendocrine tumors. My doctor might be upset. That's not true. If your doctor cares for you, they will be happy that you're seeking our opinion because we want the best for you. They will be expensive, not necessarily. Second opinions many times are paid by insurance. It's too difficult. It takes a long time to get an appointment, a lot of paperwork. It might take some time depending on how busy the center is, but typically the centers, they have patient navigators that help you to get everything ready for the visit. And my health condition isn't life-threatening, so I shouldn't bother. Well, shouldn't bother. That's actually the opposite, right? You have the energy now to go and travel and see experts in the field. So do it at least once. Take advantage of that. Many folks are doing virtual visits now. Just be careful. Don't go into your seventh opinion, because then it's, if you see 5 different docs, you might have 5 different opinions, so could get too overwhelming if you seek too many opinions, so just watch for that. Also, try to understand that in the centers there's and this is a general actually point, role of kindness. You know, find a team that you feel comfortable. Life is too short, and your team is is going to be, your doctor is going to be your best friend. So find a doc that you connect with. So my take-home message: find a primary oncologist and team that you trust. Doesn't have to be a NET specialist, but if your team is not part of a NET Center of Excellence or is not NET friendly, make sure to communicate and find a second opinion in an appropriate place. Be your own advocate. Only use reliable sources of information. Supportive groups are amazing, but obtaining true medical advice from people that's not aware of your case is dangerous. So not 2 cases are the same. So when you share things on Facebook or Instagram, or your case may be different from someone else. So that's why you are on Reassured and someone else is on everolimus. And the multidisciplinary teams really offer the best perspective in planning the best treatment, management, and care plan for you. So that's what I have. And then, so I was supposed to be here 2 years ago, and the pandemic hit. I had bought this suit to be here and be my zebra. So 2 years of COVID, 20 pounds. I'm no longer fit that. So, well, that's okay. And then while the weather is beautiful and sunny here, these were Easter last week with the kids. We still have snow in Utah. Thank you.